The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss securing your care preferences. My name is Vince Rock, Program Manager here at the American Brain Tumor Association, and I'm delighted to introduce our speakers today, Celeste Galati and Randy Bellisomo. Celeste Galati is a member of the Life Matters Media Board of Directors. She holds an MBA and a Master of Labor and Industrial Relations from the University of Illinois at Urbana-Champaign, and has completed the Philanthropy and Nonprofit Organizations Certificate Program at the Northwestern School of Professional Studies. In addition, she has actively supported the American Brain Tumor Association since 2002. Randy Bellisomo is president and co-founder of Life Matters Media, a Chicago-based 501c3 dedicated to providing information, resources, and support for all involved in end-of-life decision-making. She also works as a journalist at WGN-TV and Reuters Health. She is a graduate of the University of Notre Dame, Northwestern University's Medill School of Journalism, and received a doctorate in bioethics and healthcare policy at Loyola University Chicago in 2017. Ms. Galati and Ms. Bellisomo, thank you for joining us. You may now begin your presentation.
Thank you. Greetings, everyone. Thank you so much for joining our session. Before we start, we should mention we have nothing to disclose. Our session, Securing Your Care Preferences. We're thrilled to be in your company and delighted so many of you registered to join us. We're very grateful for your time. We recognize it's very valuable, and that value is something we're going to talk about today. The focus of our session is on communication, verbal and written. What's being discussed and what's being overlooked. Oftentimes, and I know this from experience as a caregiver myself, discussions about a cancer or a brain tumor or some other serious illness often center on CAT scans, surgical plans, radiation, MRI appointments. However, such a diagnosis and the decisions that follow, we feel, require some reflection on who we are, what are our values, what really matters to us. This kind of discussion requires us to go a little deeper in the dialogue that we have with our families and our physicians, and I promise this communication will prove mutually beneficial. It's a big picture stuff without overlooking the details. Details of brain tumor therapy, of course, are important, and to prove that we do pay very careful attention, we present this disclaimer. To introduce ourselves, my name is Randy Bellisomo. My background is in communication, journalism specifically. The primary place I do that is in Chicago at WGN Television as a reporter. That is what I do for a living. But what we're doing today, starting the conversation, is what I truly live to do. That's because I know firsthand the enormous impact of relief, of clarity, of confidence, of true alignment of minds and hearts that the discussions we're having today can have on a patient and family. I also know firsthand from my own experience difficulties that are experienced in their absence. That's why our organization goes all over the area here in Chicago to patient advocacy groups, senior centers, churches, libraries, to help people have a say in their end-of-life care. We hope that care isn't delivered for years, decades, but we are all terminal eventually. So we acknowledge that, discuss what it means, and move on to live our lives. We invite you to go to our website, lifemattersmedia.org, if there's something we missed today, or to get in touch with us. So we can get to it. We ask you if you've thought about the medical care that you would want at the end of life, and if you've discussed that care with someone else. The ABTA serves such a wonderful purpose in helping those diagnosed to live well, and I remind you as we talk that living well is what this discussion and planning is all about when you think and discuss the care that you hope for with your families or providers. And for those of you not living with a brain tumor, you certainly don't have to have one to be needing to think about these issues that we're discussing. Celeste is going to join us now to share how to get started.
Thanks, Randy. My late husband, Lou, was diagnosed with a brain tumor in 2002 at the age of 31, 2 years after we were married. Over the next 5 years, Lou had 3 brain surgeries, radiation, and countless courses of chemotherapy. Despite all of his treatments, he continued living life to its fullest and pursuing his passion for travel. In this picture, we are celebrating after renewing our wedding vows on our 5th anniversary in the Amalfi Coast of Italy. We also became very involved with the American Brain Tumor Association, where we met many wonderful friends and attended numerous events, including the Patient and Family Conference each year. Here we are at the Path to Progress Walk with our family and friends. One of the things that I learned from our experience is the importance of creating a quality of care plan, ideally long before decisions need to be made or a crisis occurs. This is true for everyone at every age, whether we are healthy or living with an illness. In order to do so, we must accept our mortality, discuss goals of care, and infuse conversations with loved ones with our beliefs and values. I was very fortunate that Lou initiated this important conversation with me. In fact, one night after dinner, Lou sat me down and said that although he felt good and remained full of hope, he accepted that he had a serious illness and wanted to discuss his end-of-life wishes and decisions that he would want me to make on his behalf if he was no longer able. I was shocked and resistant at first, but quickly realized how important this conversation was for Lou, and ultimately for me. I never felt for 1 minute that having these conversations took away hope from Lou. To the contrary, the conversation seemed to empower him and free him to live more fully. The elephant in the room had been addressed. It was as if a weight had been lifted. One of the things that Lou shared with me was that he absolutely did not want to die in a hospital, if at all possible. To Lou, the hospital represented illness, sadness, and stress, not the peace and comfort that he valued and sought at the end of his life. Had we not had this conversation, Lou would have likely been one of the many individuals that, despite not wanting to die in a hospital, ultimately do so, as during the final phase of his illness, his family pushed to keep him in the hospital. I think they believed that as long as Lou was in the hospital, there was a possibility that something more could be done, and they were not ready to confront the reality of the situation themselves. However, because of our conversation, I had the confidence to push even harder for Lou to be transferred to a hospice facility where he was able to pass in peace, surrounded by his family and friends. One of the moments I will always remember is Lou looking up and acknowledging that he was no longer in the hospital, breathing a sigh of relief, and thanking me. I now know that Lou's greatest gift to me was initiating this difficult but vital conversation. But why is this so difficult? Well, there are many barriers to having these conversations. Common among patients is the fear of the prognosis and fear of disappointing their care team. After all, doctors are trained to make people feel better, and what if that's not the case? It can be very difficult to bring up a conversation that may be perceived as the doctor letting us down. Also, Lou took great pride in being a survivor and facing each new treatment head on. What would happen if he shifted his care goal? Would people think he gave up? Would he be abandoned by his healthcare team? Would he still be a survivor? On top of that, he was extremely concerned about hurting his family. In truth, while he was alive, everyone was amazed at how Lou lived each day full of hope while enduring what seemed like endless treatments. However, almost 10 years later, I can definitely say that Lou's greatest legacy was not how he handled the treatment, but how he inspired so many by courageously accepting and discussing his mortality at such a young age. And doctors, they have barriers too. From an oncologist's perspective, time is a big one. It's really hard to open this emotionally laden conversation about values and goals when there are immediate issues to be addressed and only so many minutes left in the appointment. It also could cause a conversation that exposes issues that a doctor can't fix. And doctors go into medicine the vast majority of the time to fix people, to help them get better and not give up hope. But medicine for many years has denied to address what needs to happen in the 100% of times that the outcome becomes ultimately impossible. But that's starting to change. I'd like to share a few statistics that highlight the importance of having these conversations. More than 90% of people think it's important to talk with their loved ones about the end of life. However, less than 30% have. 60% of people say that making sure their family is not burdened by tough decisions is extremely important. And 70% of people say they prefer to die at home, but almost the same amount die in a hospital, nursing home, or other long-term care facility. Although we know sometimes that is for the best. 80% of people say that if seriously ill, they would want to talk with their doctor about end-of-life care. Yet only 7% report that they have had an end-of-life conversation with their doctor. Also, it has been shown that families who engage in open and explicit end-of-life conversation suffer less complicated grief, which is why this conversation is truly a gift to your family and loved ones. Finally, 82% of people say it is important to put their wishes in writing, yet only 23% have actually done it. I'm now going to turn it over to our friends Jerry, Elaine, and Kramer to show us how not to have this conversation. Then Randy will share with us how to do it right.
Jerry, you ever seen the movie The Other Side of Darkness?
No.
It's about this woman in a coma. Well, I couldn't finish watching it, so I want you to read this.
I, Cosmo Kramer, having just seen the movie The Other Side of Darkness, and not wanting to be in a coma like that lady in the movie, hereby want Jerry Seinfeld to remove my life support, feeding machine, lung blower, etc., etc., etc.
Can you do that for me, buddy?
Well, I don't know if what you have here constitutes a legally binding document.
Well, I'm going to type it up.
Yes, well, of course, but even so, you may want to talk to a lawyer.
Well, Jackie Childs, he put a restraining order on me. I'm not allowed within 200 feet of his office. I couldn't even give him his Christmas present. You take this out of the garbage?
Yeah, it's still got some spring in the string.
Jerry, this is a piece of junk. How are you going to be the executor of my living will? You see, you can't let go.
Trust me, Kramer, given the legal opportunity, I will kill you.
I wish I could believe you. Hey, Elaine, do you have some free time tomorrow afternoon?
Me?
Yeah, because you're perfect. You're a calculating, cold-hearted businesswoman. And when there's dirty work to be done, you don't mind stomping on a few throats.
Oh, come on.
Situation number 4. You're breathing on your own, you're conscious, but with no muscular function.
Well, would I be able to communicate?
I don't see how.
Yeah, I don't like the sound of this one.
Yeah, let's pull the cord.
Yank it like you're starting a mower.
Moving on. You have liver, kidneys, and gallbladder, but no central nervous system.
Well, I gotta have a central nervous system.
Okay. 1 lung, blind, and you're eating through a tube.
No, that's not my style.
Boring.
All right. You can eat. The machines do everything else.
I'd stick.
Yeah, stick. Because I could still go to the coffee shop.
So that is an example just to emphasize how this conversation should not go, but too often we think about end-of-life medical decision-making in those terms, and it's not a checklist of crazy medical options because we can't possibly consider every scenario. If you take a step back a minute and think about the preparations that take place when somebody's expecting a baby, there's so many things people do. They prepare a nursery, have a shower, pack a bag, go to the hospital, arrange maternity leave. Everything is in place because it's so overwhelming. The considerations at the end of life are similar, but unlike childbirth, there's something everybody does, but it isn't something people plan for at that level. We think it's easier to think about this conversation as considering what living well means. And it's personal. Some people want to have a baby at the hospital. Some people use a midwife at home. It's their prerogative, and our end-of-life choices are too. It's been shown that most doctors think everybody wants to live longer, but most people really want to live better. So to consider what living better, living well means to you, there are a few things to ask yourself. Think about the things that you do that give your life meaning. It could be spending time with our families, gardening, reading, going to religious services, outings with friends. The next question is harder. What can you not imagine living without? Of all the things that give your life meaning, what's non-negotiable? What can you not imagine living without? The third question, what fears or worries do you have about future medical care? I can say that most people, when citing their end-of-life fears, fear pain more often than any other issue that might arise. Even more often than they say they fear death, they fear pain, but it's different for everyone. Fourth question, who or what helps you in difficult times? Is it your family? Is it your faith? Is it just getting fresh air? If I were to have this conversation after I consider these with my medical decision maker, and these are hypotheticals, I could say to Celeste, Celeste, I want you to know something important to me. I really enjoy spending time with the kids in my family. I really enjoy fresh air. I really enjoy going to church on Sunday. What I can't imagine living without, I can't imagine living without the ability to communicate. I really enjoy interacting with people, and I can't imagine living without the ability to communicate to you sitting next to me. Fears or worries I have about future medical care, maybe I'm really afraid of pain. But then again, I'm really afraid of having anything that interferes with my ability to communicate. And who or what helps me in difficult times? Someone sitting close to me and engaging with me and talking to me about current events and treating me like I'm still part of the world going on outside. So that's like an end-of-life conversation, because that could tell Celeste that company, having companionship really helps me in difficult times. They shouldn't do anything that infringes on my ability to communicate, because I can't imagine living without that. And try to keep those things up about what gives my life meaning. If I can't go to religious services on the weekend, well, that's important to know that that's important to me. And so maybe you can have the pastor visit me in the hospital or at home. So these are how we can think about what living well means to us. When we know the answers to those questions, we know the things that are essential to communicate to those closest to us, likely to be there if we're ill, hospitalized, or need someone to speak on our behalf. We have this conversation to enable those around us to act in our best interests, in alignment with our values if we're unable to speak for ourselves. How do these values get translated to actual medical care? Well, end-of-life care has become very complicated. In this age of patient autonomy, patients and families are faced with difficult decisions that they may not be equipped to make. The most urgent are the use of life-sustaining treatments, which may be beneficial in some circumstances and not in others. Treatments like CPR, intubation, nutritional support, kidney dialysis may arise as one's illness progresses. Choices exist, such as when to start, when to forego or withhold, and how or when to maintain comfort. CPR, for example, is a treatment we should all decide on ahead of time, but we can't do that until we learn what CPR is all about. It's been shown that fewer than 1 in 5 patients who receive CPR in the hospital, cardiopulmonary resuscitation, leave the hospital after an average stay of 2 weeks. More than 30% of these survivors will go to a nursing facility or rehab center. Less than 3% of older, weaker nursing home residents survive that intervention. Whether or not to accept CPR may depend on your underlying illness, overall health, and your definition of living well. I can tell you that some people see those statistics and say, those statistics aren't very favorable. Others will say, that's pretty good odds, let's give it a shot. It's entirely up to you and what your definition of living well truly is. A framework exists to assist with specific end-of-life decisions and medical decisions in general. We encourage you to think about this whenever you have a decision to make, and it doesn't have to be an end-of-life, life-sustaining treatment procedure. It's important to have a basic understanding of the treatment being offered, whether it's emergent treatment like CPR or a chronic treatment like kidney dialysis. Having a basic understanding of the treatment, the effectiveness, the time commitment, the evasiveness, is imperative to make an informed decision. Understanding the benefits and burdens, and most importantly, exploring the goals of the therapy. Is this therapy or treatment going to make the condition better or sustain the condition as is? Either are okay as long as it is aligned with your goals. If you're hospitalized and your goal is to get better, to live an independent life, will this therapy help to achieve that goal, or will the therapy require you to remain hospitalized? So here are the questions to ask yourself. Would undergoing CPR when your heart stops help you meet your goal of living well? Or what outcome would you expect from chemotherapy? What would be an unacceptable outcome of radiation? What fears or concerns do you have about making a decision to go into surgery? Evaluating your own goals and wishes, educating ourselves about the issues that may arise, and discussing those wishes with our families and medical providers are the basis of the process of planning ahead. To make those wishes secure and legal, we can translate them into an advance directive, a legal document that goes into effect only if you're incapacitated or unable to speak for yourself. Advance directives help others know what kind of medical care you would want in the case of serious illness or injury. However, advance directives do not let people know what kind of care you want for the first time. An advance directive reflects a conversation that you have had about living well with your loved ones and medical providers. An advance directive allows you to communicate in writing these values and desires related to your end-of-life care. It's important to remember that advance directives are documents that we call living documents. They can change as your life changes, your personal life changes, your health changes, your religious life, or your family relationships. Advance directives come in various types, and that's why this topic can be anxiety-provoking or confusing to people, because many of us have seen some of these documents before and we don't know the difference between them or which one's right for me. What constitutes an advance directive? At the top left, you can see someone whispering something. Oral communication counts. If you express your wishes to a trusted loved one and loved ones, and everyone in a hospital room knows exactly, well, this is what John wants. Mom always wanted to live this way, not that way. That counts. We encounter people in the course of our community planning sessions that don't feel comfortable filling out an advance directive for any reason, and there are a number of them. And what we say is to be sure that they verbally communicate to everyone who is likely to show up when a medical decision is made, so everyone is on the same page. However, written advance directives legalize those preferences and are much more secure. You can see power of attorney for healthcare, 5 wishes. These are these are written advance directives. And you can also see a living will, which oftentimes when we talk about advance directives, people assume that's a living will. A living will is actually embedded in the state, wherever you are, power of attorney for healthcare. And that's how we recommend discussing and completing a living will, because a living will in and of itself, like in the form in the lower left-hand corner, only applies to those who are terminally ill, who have a terminal condition that is diagnosed by a doctor. If I only had a living will and I were to leave the session and get hit by a bus, and my medical decision maker comes to the hospital with a living will and says, here she is, she didn't want life-sustaining treatment, it wouldn't be effective, because I am very grateful to not have been dealing with a terminal illness at this time in my life. So that's why we recommend your power of attorney for healthcare at the very least. There is another form, which is the physician orders for life-sustaining treatment, depending on your state. It could be called the PULSE form. It could also be called the POST form. I've seen it called the MOST form, medical order for life-sustaining treatment. This is for completion with your doctor. Not to get too caught up in the legal language, it's not an advance directive. It is a medical order. This means that it is to be completed with your physician. It is recommended for those who have been diagnosed with life-limiting illness. The criteria for completion is that doctors would not be surprised if the patient were to pass away within the next 12 months. It is also for those who are extraordinarily frail, weak, nursing home patients, or those with extraordinarily strong preferences that are absolutely certain and who have recommended, or who have considered these preferences well. It is a binding medical order. It travels with you wherever you go, whether it's a hospital, nursing home. And the reason it is more specific and it's not for everybody is because it breaks down very specific medical treatments. CPR, yes or no. Medical interventions, yes or no. Antibiotics, yes or no. Intensive care, yes or no. Artificial nutrition and hydration, yes or no. This is not for relatively healthy people, because relatively healthy people don't need to get that specific, because it's impossible for us to predict what's needed and when, because we don't know what we are dealing with. If you are a candidate, if you think that you're a candidate for the POST or the POST or the MOST, however we call it, is the medical order about your end-of-life care, we ask you to talk to your doctor about it, because doctor's signature and updating into the medical record is what makes that active and binding. This is not something that we can do on our own. I'd like to talk to you about what can be done on our own, which is, we're going to talk about a few things. Some of you may know about the 5 wishes form. This is a conversation, this is an advance directive. It's legally effective in most every state. It is much more specific than any other advance directive that we talk about today, because it is so detailed. We're not just talking about life-sustaining treatment, we're talking about their 5 wishes. Who makes care decisions for me? What kind of medical treatment I want or don't want? How comfortable I want to be? How I want people to treat me? And what I want my loved ones to know. There are places to write all of these answers, and that's why this is great for some people. Some people take to this, say this is a perfect opportunity to communicate all these things about my end-of-life wishes and preferences. And some people see this and say, this is overwhelming. It's too much. I'm not doing that. We see both types of folks all the time. What I can recommend, what we recommend, that if you're interested in the 5 wishes, it's a great conversation tool. You can get these forms. They've come from an organization called Aging with Dignity, which we will reference at the end of the presentation. It is a nonprofit organization. It's several pages. They ask for $5. They will mail you one. It's a great conversation tool. It can also be used as an advance directive. We just don't like them as your only advance directive, because they are cumbersome. And if paramedics are rushing in and they're leafing through documents and pages trying to figure out what's the medical wish, who's the medical decision maker, it's a lot harder than the form that we're going to talk about next. Which is and this is the POST again, which I gave you a little information about the POST, but you could see, I'm sorry for going back and forth, but this is the document for people that are recommended for use for those who would not be surprised if they pass away within 12 months. This is a medical order, not an advance directive, but a way to communicate end-of-life preferences with your physician. What we're really here to encourage everybody to do today is to think about your state's power of attorney form. We think this form is for everybody 18 and older, whether you're living with a brain tumor, you're a caregiver. If you have a student in college who's 500 miles away, we think everybody 18 and older should have this form. The healthcare power of attorney appoints in writing an agent that you can see on your screen, also known as your medical decision maker, surrogate. There's a lot of terms that get thrown around, This form talks about your agent, same thing, to make medical decisions in the event that a patient loses decisional capacity. The person will have decision priority over all other possible people. And this agent has authority to make decisions in all situations which the patient is incapable of making health decisions, not only in the case of terminal illness. The proxy is expected to be consistent with the patient's known values or express decisions to act in the best interests of the patient. Remember, this form reflects in writing conversations that you have already had with your decision maker. So we put the patient's name, the adult's name, the agent's address, which is far less important than the agent's phone number. We say this all the time. Nobody answers the phone anymore if you don't know who's calling. If it's an unrecognized number, put down every agent phone number you know. And when you pick a healthcare agent, which we'll talk about in a minute, please encourage please let the person know that if they get a phone call, they need to answer it. This agent also has the following roles, which we'll talk about in a minute, but this is why it is so important to appoint a healthcare agent, because this person accepts, withdraws, or declines treatment, agrees to admit or discharge you from a hospital, home, or institution. They determine where you receive care. They have access to your medical and mental health records. And if anybody's familiar with HIPAA laws now, this is a really big deal because medical records are hard to access. They also carry out the plans you've already made, or if you haven't made, they decide about your organ donation, your tissue donation, and they have one role that extends beyond death. That if you have not already made disposition or funeral plans, the agent has the authority to carry out your plans for disposition. So the patient is then given an option to choose a general statement about their values. Now, these statements are left general on purpose, and they're used to guide an agent in decision making. They are not specific, and some of you might think, and your agent might think, they're kind of confusing. And that is, again, on purpose, because the conversation part about living well is something that you and your agent need to talk about together. The choices are, in most states, you'll see something like this. The quality of my life is more important to me than the length of my life. Or, staying alive is more important to me, regardless of the quality, the cost, or the burden. There is also space to add text with any specific instructions. For example, no blood transfusions. We talk to people who are against blood transfusion for their own religious reasons. That's important for people to know. No dialysis. You saw your uncle on dialysis in 1967 and you decided then that is something you fear. That's a place to put that in. Anything else that you want somebody to be sure of. Control my pain as well as possible. I don't care if I'm unconscious. This is entirely up to you. It then requires the signature of you, the patient, or the person completing the form, the date and signature of the single witness. Now, the witness cannot be your agent, related to the agent, your physician, or the owner or operator of your healthcare facility. There's also room to appoint successor agents. Your agent doesn't answer the phone? Here's number 2. You appoint your nephew to be your healthcare agent. He's out of the country. You put your niece down too. Healthcare power of attorney, before we go on any more about the agent, I want to tell you, this is an example of our state's form here in Illinois. You can obtain a copy of your state's power of attorney for healthcare online. They are state sanctioned. They are legal when they are completed correctly. They require the person's name and address and phone number. However, we also recommend, and we'll put it up at the end, the site Everplans, and we're going to put that on our resources. As far as we can tell, that's the best and only site that we see that has each state's power of attorney for healthcare listed in alphabetical order online, and you can download it there. So if you're in Arizona, Whichever plans can direct you to that form. Also, the Arizona Department of Public Health, Colorado, and so forth. Again, this is an Illinois form, but we have found that they are very similar. Also, a question that we get often, are you sure it's legal after we sign it? Don't I have to get an attorney? No, we talk to people all the time that pay $400 to go get an attorney to do this for them. No, waste your money. You do not need an attorney to do this. States, as far as we know, here in Illinois, in most states, they do not need notarization. The American healthcare system and public health departments have done something right in trying to make the barriers to communicate your care preferences as easy as possible. And we say if it's as easy as possible to do this, please, by all means, don't let anything get in the way. So once you complete this form, reflecting your healthcare wishes, what do you do with it? Make copies. Better yet, take it into your doctor and have your doctor make copies for you. Give one to your healthcare agent that you're appointing, and your surrogate agents, your secondary agents, and then make sure that the doctor puts one in your electronic medical record. Tell all your family members and friends what your wishes are. And in many cases, we encourage you to give all of your family members a copy of your healthcare power of attorney. Just as it's important for you to communicate to your healthcare agent that you would like them to be your healthcare agent, we think it is equally essential to tell all those close to you that they're not your healthcare agent, and you can do this compassionately, lovingly, with care. I've selected John to be my healthcare agent. I want you to know that he's going to carry my wishes. This doesn't mean any ill will to you, but he's in charge. So there's clarity, and people aren't fighting over power in a healthcare setting. If you go to a hospital separate from where your physician is, if your physician's office is not in a hospital setting, give the staff there a copy to include in your records, because you may, and you most certainly can, change your advanced directives in the future. Please keep track of who receives a copy. Keep a list of who has a copy of your advanced directives. We encourage you to review these discussions and documents from time to time. We said it was a living document. That means it can evolve. It's because you might want to revise your preferences for care if your life or your health situation were to change. Examples of these changes: marriage, divorce, death of a spouse, a change in a diagnosis, evolution of an illness. And if those preferences change, make sure everyone important to you is up to date. We think it's important to know, for everybody close to you to know, I should say, what's in your advanced directive. Because many of you might be familiar with a scenario of a mother, for example, hospitalized with a daughter. Her daughter's there who lives next door and sees her every day and is primarily responsible for her health care. And that daughter is making decisions on her mother's behalf and in her best interest. Things are getting serious, so serious that the daughter, who calls once a year and missed last Christmas and Thanksgiving too, because she was in LA, flies in from California and comes straight to the hospital with her luggage and says, "Hold it, I know what mom wants, stop right there. My sister is so wrong." Those characters exist in our families. I don't think only in mine. So it's important that the person at the center of all this informs everyone of everything, what matters to them, so the whole family is on the same page. However, your agent is the one who has to be clearest on all of this. Sometimes your agent isn't your spouse. There are many people who say that they don't want their spouse to have that kind of stress, that they would rather give that responsibility to somebody else, or that their spouse would want to keep them around forever, or they speed the process of the end of life up. I don't know anybody's situation. I can see that happening. It's time to get rid of this person. So they have to be clear on your care. It's also the person that you think would be there in a crisis, who would respond. It is possible to have, and it happens a lot, to have a healthcare agent who does not live nearby. That's why phone numbers are included on your advanced directives. However, it is very beneficial to have someone who is there at a hospital, for example, looking at a patient, what we call the eyeball test, looking at the doctor, talking to the doctor in person, and can respond best on that patient's behalf to whatever is happening right there. So geography does matter. It's not a deciding factor, but it's something to take into consideration. So that might mean you don't pick your daughter across the country, but your son who lives a mile away because he is more accessible. It's also important to think this decision through. That's what we're asking, because if not, your state will appoint one for you through law. This is an example of what we call the State Healthcare Surrogate Act in Illinois. It is likely similar, if not identical, in the state where you are. In the absence of a living will or a healthcare power of attorney, which again we recommend, it goes to the patient's guardian, the spouse, the adult son or daughter, parent of the patient. In reality, doctors will tell you that it goes to whoever answers the phone first. Now, you might look at this Healthcare Surrogate Act and say, that's okay, I don't have to complete an advance directive because the default is the person that I would select anyway. Then why do we do this? Because only a legally appointed agent in an advance directive has the right to withdraw medical care. You cannot do that if you are not legally appointed through an advance directive. So we strongly emphasize doing this for clarity, even if that's not what you want, but just for clarity and legal purposes, it makes things so much easier. As the powers that they have, again, or they have the decision to accept, withdraw, or decline treatment, decide where you receive care. If you are at the end of your life and is it time for hospice? Is it time for the ICU? They decide this. They obtain access to your medical records, confer with your medical team, ask questions and get answers to understand the options and determine if a course of action aligns with your values, your preferences, and your definition of living well, which you have considered and communicated. And as we said, the agent's responsibility extends beyond the patient's time of death to organ donation and additionally disposition plans. If they are not in place, your agent has the authority to create them and carry them out. So it is important to think this decision through. Who is your agent? How are you going to communicate to your agent what living well means to you? And with that, we thank you. And we would be happy to take your questions after we mention some resources. Our website, we invite you. We have a lot of resources on there. We also have a subscribe to our email. We send out updates and information about this topic, decision making. You can subscribe online. Everplans is the website that we reference that has state by state power of attorney for healthcare forms. Of course, the ABTA has a wonderful resource on advanced care planning, which is a term for considering, communicating, and documenting our career preferences, which is the core of what we're doing here today. Aging with Dignity provides that 5 wishes form that we referenced. The rather lengthy advanced directive, which is a great conversation tool. They're out of Florida, nonprofit. They're doing great work. Caring Info and the Conversation Project are also websites that you can check out. We're happy to answer questions about any of that, but with 15 minutes left, we would like to turn it over to you. This is we're going to leave up our contact information. Celeste and I are always happy to help people in this process. We know it's difficult. We also know it's one of the most important things that you can ever do for yourself and your family. So if we can ever be privileged to escort you in some of these challenges, don't hesitate to contact us.
Thank you, Ms. Bellosomo, and thank you also, Ms. Galati. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. So our first question is, how long are advance directives valid?
Oh, that's a great question. They are valid until the patient dies. And however, there are many situations where you update an advance directive, change your agent, and there's another old advance directive floating around. And one adult son comes in and says, I have mom's advance directive, it's here right here, and it's dated 2015. And then the daughter, who hadn't been in communication for too long and is in disagreement, comes in and says, well, I have this advance directive from 2005. Well, medical providers are going to follow the most recent advance directive, but we encourage everyone to keep track of where those advance directives go, so you can get them back and destroy them, tear them up and throw them away, so they don't produce any more confusion. So they are effective upon signature and witness signature forever.
Thank you. What should someone do if they don't have anyone available to act as a healthcare decision maker?
That's a great question. And that's something that we run into a lot with the senior centers that we provide education for all over this area. And it's hard. And the answer is not the same for everybody. The quickest, the easy, one of the solutions that has been provided by this PULSE form, that medical directive, that medical order that's very specific, is that it's completed by your doctor, and it is communicating a whole variety of preferences now and becomes legally actionable upon your doctor's signature. One of the beneficial things about that form, although that wasn't its intent, is that you don't appoint an agent in that form. You don't need an agent. The PULSE form states your decisions in advance, and they are to be carried out. There's no decisions to be made because most of them are all made for you. And that the other situation, if somebody's not ready for that, it's harder, and it involves trying to determine relationships, people geographically nearby. It doesn't have to be family, it doesn't have to be friends, but what are you willing to do for somebody? Are you willing to be somebody's agent in the same situation? If they would be your agent too, whether it's through your house of worship, community group, etc. This is a situation that too many people face, and it's often not until it gets broached by somebody brings it up, that you realize that they're in the same position you are. And that's why you don't have to know the patient terribly well. You don't have to be emotionally connected to the patient. But if you know what their definition of living well is, it's not like you have to have a best friend for the past 60 years that's going to do this for you. It's just about finding somebody who would do this for you, and maybe you would do it for them too. So there's no one answer to that, but those are a few options.
That's great, thank you. Our next question, if the default option in the Surrogate Act would be one's healthcare decision maker, why is it important to appoint one legally?
Right, because again, without having a legally appointed power of attorney for healthcare, the surrogate and the Surrogate Act, the default option, is not able to withdraw medical treatment. If LifeSustaining, that's one of the things that makes end-of-life medical care so challenging, is because it's a lot easier to never start something than withdraw something. And so if some life-sustaining treatment is underway and the family wants to withhold and pull back from that, whether it be a ventilator, et cetera, unless you're a legally appointed agent, you can't do that. So that's why we encourage everybody to have this.
Great, and our last question for today, in your experience, what are some of the common misconceptions that people have about advance directives?
I would say, from just again personal experience, is and not only with my husband but with my mom, who just recently passed from dementia. It's getting the conversation started, because it's kind of the feel of, oh my God, I'm recognizing my mortality, I'm really sick. So I think it's more of the hurdle to get the conversation started. And as far as I think the other thing I've heard is people feel like it's taking control away from them. I've heard some people say, that somebody else is now going to make decisions for them. So I think it's understanding that it's absolutely not the case that somebody's making decisions for you. It's only if you cannot make them for yourself. So I think that's the number one misconception I've heard. And then and then not wanting to broach the topic because it is a difficult topic that, as we talked about, some of the barriers to getting that conversation going. But I think it's just not fully understanding, what the powers are, what powers you still always have, etc.
Great, thank you. Okay, well, that is all the time we have for today. Thank you all for joining us, and thanks once again to Ms. Galati and Ms. Bellosomo for their wonderful webinar presentation. Aside from our free educational webinars, the ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, please visit ABTA's website at abta.org or call the ABTA Care Line at 800-886-2282. Let's pause for just a moment to conclude our webinar recording.